stuff on prescribing. I'm going to put a disclaimer, which I've written on the first slide, which is that I haven't done an OSCE either. So most of what I'm going to tell you today is sort of like stuff that I've made with Anoush and tips that I've got from older years. So if you find you're having a really hard time, take it with a pinch of salt, and just like the best thing with prescribing is just to practice. It's the only way I got the hang of it. And also only use the good hospital drug chart whenever you practice, because that's the one that will be in the exam. Don't use anything else. I've linked it for you, and that's what we're going to edit today. And try not to look at any notes or anything during this. Try to just like rely solely on the BNF. Okay, so general tips for prescribing. What are the two key like questions you have to ask when you're prescribing something?
To be fair, not even prescribing, when you're documenting generally.
Make sure it's legible.
Make sure it's legible, yeah.
Before you even write anything, what do you want to check?
You want to check it's the right patient.
Yeah. Yeah, who you're giving, how much, perfect. Okay, so is it the right patient and is it the right drug? So when you explore, like, is it the right patient, you want to like always check their details, and they will give you all of the details in the station. And can anyone think 2 extra details other than name, date of birth, and hospital number that you need for prescribing?
Allergies.
Allergies, yeah, and
Weight and height.
exactly.
Weight, okay.
Weight, yeah. So there's no like hard and fast rule, but I've been told by loads of people to like get used to just writing in capitals, and that way you're like sure that your handwriting is clear. But do whatever is right for you as long as it's clear. In terms of the right drug, you want to know what drug, what dose, why, and is it the right, like, is there any contraindications? Are they allergic at all? Okay, so I'm not going to spend too much time on this, but this is what a drug chart looks like. It's got 5 pages. The front one just has like all of the patient details, and then it has the PRN prescription. So like the one, not the PRN, sorry, the once only. So like in a exam, the buzzword might be the stat dose. And then it talks you through all other different categories that you can prescribe medication in. So the anticoagulation, thromboprophylaxis, and the oxygen. This page is the one I would say do last in an OSCE station. Okay, so yes, it's good practice, whoever is being admitted for whatever reason, to have oxygen prescribed and VTE prescribed. But if that's not the task they've set you, don't waste time on it until you've done it. So always do this bit last, to do what they've asked you first in the station, because you don't know what they've asked you to do and it could take ages.
It's worth pointing out that they will, yeah, as Preena said, they will tell you whether you should prescribe on once only, or they'll tell you to prescribe in regulars, and they'll tell you exactly what you need to do. So read the brief. I mean, and they usually, like in 4th year, even tell you what drugs to prescribe. I lost marks in my 4th year OSCE because I used the wrong heparin, because they told us to use a specific heparin and I'd memorized another dose. So read the brief.
And again, sometimes there are indications for not giving VTE. So go back and look over the history that they've given you just to check that you're not actually shooting yourself in the foot by prescribing it. Anyone think of any indications for not giving VTE?
If they have a bleeding disorder?
If they have a bleeding disorder, yep. If they're currently bleeding, yep. They're the 2 big ones. The other ones are, yeah, the other ones are if they're already on anticoagulation. Don't mess with it, basically. Okay, the next page is regular prescriptions. And again, as Anoush said, they'll tell you to prescribe it in the regular prescriptions bit, or if it doesn't go anywhere else, it's probably a regular one. The next bit is the PRNs, and then your infusions, and then the final page is any anti-infectives. And then my top tip would be, once you've done that, go back and check it's the right patient. And you might realize, like, so for example, I can't think of a situation, but if there was one where you needed to give more than like 4 antibiotics, or like they'd already been on 2 and they were crossed off and then there was only like 2 boxes left and you used to give a third, you can always have a second chart. So always go back to the front page and change the chart number if there's a second chart, or if it's the third chart or whatever. Okay, so we're going to just crack on and practice. There's 2 short cases, 1 long one, I think. So the first one is you're an F1 on take. Moira Rose, does anyone get the reference? That's her date of birth, that's her hospital and her weight. She is a 45-year-old who's come in with fresh red blood in her vomit on a background of alcoholic liver disease. You go to see her in the cubicle and the nurse tells you that her blood pressure is 78/42. Prescribe the appropriate fluid resuscitation for her. So everyone whack out your chart, have a go.
And again, at this point, it's worth pointing out, in an OSCE station, they'll tell you if it's resuscitation fluids or it's maintenance fluids. They will tell you. So don't worry. If like you wouldn't be asked to randomly do maintenance fluid, they will specifically state if they need that.
Okay, I'm going to give you guys 2 more minutes. 1 more minute for this one.
Have you guys been told how long your OSCE stations are? Sorry, I've just remembered because they change them every year. Finish prescribing before you answer, but yeah, let us know, just so we can plan for future sessions.
Okay, I'm going to start talking again. So I'm going to close the chat for a second. Okay, so first thing you should have done is put her details in. So I gave you all of them. And the top tip that someone gave me in final year is that like stuff like date of admission or like date on chart or your bleep, don't make it up. They'll tell you in the station, or put down the date that it actually is. So my friend had just got used to writing 1, 2, 3, 4 for everything, and that was the bleep he wrote. And actually, you're given a bleep in the station. I know I didn't give you one, but just for future reference, like they'll give you most of the information you need. So she's an adult. She didn't have any signs of. She was hypotensive, and you knew that she'd been vomiting. There was blood on it. So what was the likely diagnosis that we're considering here?
Varicose bleed.
Yeah. So you wanted to give her 500 mils over 15 minutes of sodium chloride. And for anyone who wrote saline, that's wrong. Always write sodium chloride. There's actual studies out there which show that if there is a nurse who doesn't know that saline is sodium chloride, the time it takes for her to find that out is detrimental to outcomes. So always write sodium chloride. NaCl is okay, yeah. I've seen loads of doctors write NaCl. I personally wouldn't, because you have the space to write it out full. So
if you can, in an OSCE, try and write sodium chloride out full. In real life, less of an issue, but in an OSCE, try to say sodium chloride.
And then this bit here where it says drug added, that means like if you're adding anything into the sodium chloride. How do I find out how fast to give the fluid and how much of it? So this is something that I would recommend just learning off the bat. It's your fluid resuscitation pathway. So you give a fluid bolus as part of your A to E, and each bolus is 500 mils of sodium chloride over 15 minutes. I've gone over it in the anesthetics lecture, so you can always go back to that one if you need to. How many fluid boluses can you give before you call for help? Does anyone know? So you give, hello? Okay, you give a max of 4, yep. So you give up to 2 liters, and then you got to get some help, yep. And when do you consider giving a 250 ml bolus instead of a 500 ml one? Any situations that you can think of? Heart failure, yeah, that's the big fourth year one. Basically, if they're ever like high risk of overload or high risk of a raised chloride, which you can check quite quickly. I'm just going to answer that on a VBG. Okay, so if we go back to the case, our main differential, like someone said, was a variceal bleed. So if this was an OSCE station, other than the fluid resuscitation, what's the main other drug you would consider prescribing? Yeah, IV telepressin, fab. Okay, so I've not done it out for you here, but in your own time, go on the BNF and practice that you can prescribe the IV telepressin. Okay, case 2 is Johnny Rose. I put his details in the corner, and his presenting complaint is shortness of breath. So what do you want to ask in his history? What are the kind of questions you'd ask in a shortness of breath history? When did it start? Yet? Any chest pain? Yet? Anything bring it on? Yet? Cough? Good. All the rest of signs? Yes. Have they been ill? Yeah. Okay, so he tells you that he's had it for 3 days and it's been worsening at rest. He's got some ankle swelling and tiredness, unable to sleep because it's worse when he lies flat. He's got no chest pain, and he hasn't been taking his water tablets because he's been on holiday and forgot to order his prescription. So what kind of things are you expecting to see on examination? Oh, I gave it away. Raised JVTP, yep. Bibasal crackles, yep. Edema, yep, good. So he's got, exactly, yeah. So he's restless and anxious at the end of the bed. He's got a raised JVP, he's got a third heart sound, and he's got bibasal crackles up to the mid-zone, lower limb pitching edema, just up to just below his knees. Okay. What is your main differential? Yeah, pulmonary edema, exactly. So pulmonary edema can be a differential. You don't have to necessarily say what it's secondary to. So it could be a pulmonary edema, it could be exacerbation of the heart failure. Okay, so here's some more information about Johnny. He's got a history of chronic heart failure. He's got raised cholesterol. Those are his regular medications, and those are his OBS. Anything concerning on his OBS? Yeah, he's got a slightly high rest rate. He's slightly tachycardic, but his stats are fine. Okay, so what investigations do you want to order? You've got someone here who's fluid overloaded and has heart failure. Chest x-ray, yeah.
If Mark was here, he would be going on about remember to start at the bedside.
I'm guessing UE means use knees, yeah. You want an ABG? Interesting. Why do you want an ABG? Yes, ECG, definitely. Yeah, okay, so I can see the logic behind the ABG. I personally wouldn't, just because he's not he's actually holding his sats okay. So I don't think he is in rest failure. If he was hypoxic, absolutely, but he's actually saturating okay. So I would rather just do the VBG and not put him through the ABG, because you're going to take some bloods as well. So he did an ECG. There's nothing interesting on that. His chest X-ray showed some upper lobe diversion and some curly V lines. Full blood count LFTs were fine. There's his renal function. And here is your station. I'm going to give you like 5 minutes, maybe a bit longer, but I want you to basically implement the senior plan. So prescribe the oxygen, prescribe his regular medications from his drug history. Don't catheterize him. Prescribe the IV furosemide and stop the regular furosemide.
Last minute. Sorry to simulate the stress of an OSCE.
Okay, so shall we go through it? I'm gonna assume, unless anyone puts in the chat that they want any more time, that we'll just go through it.
Yeah, does anyone want any extra time? Speak now or hold your peace.
Okay, let's go through it. So there was quite a few parts to this. So let's start with the oxygen first. So when you do an oxygen prescription, you can kind of prescribe any device, but if they're not already on the oxygen, the first one that they're going to start with is like a nasal cannula. So that's the logic I was taught, which was start with a nasal cannula, put it at 2 liters, and then in the additional information for the nurses, just write, please inform if requiring O2. Because if someone has a new oxygen requirement, that's significant. You want to review them. And he had heart failure, not COPD. So his SATs should have been 94 to 98. And these 2 arrows basically mean you can give it at any time of the day. Because you haven't specified, basically. So that's the oxygen prescription. The next one was prescribe a stat dose of IV furosemide now. So like I said, buzzword stat means just like you're only giving it once. So under the once only prescriptions, you should put today's date. That's a date from ages ago when I did this. The time that you want it given, the drug, so furosemide, its dose, IV, and your signature. So that was the stat dose of furosemide. And then the plan basically said, prescribe the regular meds, prescribe him some IV furosemide for the next 2 days, and hold his oral furosemide during that time. So if we start with his regular medication, he's on atorvastatin and bisoprolol. So that was literally just a case of copying off the drug history, drug, dose, route, and frequency. The important thing with statins is you give it at, do you know what, does anyone know what nocti means? Yeah, you give it at night. And the reason for that is because it works better overnight. So as you can see, I've written 10 o'clock, the time on the chart, and then I've drawn kind of a line through all of the other rows above it. And that basically means you can't give it any other time. So you just cross out all of the possible places the nurse could accidentally give it and sign. And then you just write today's date and go from there. The bisoprolol, similarly, but you don't give it at night, you just give it once daily. Most of the drug rounds happen at 8 in the morning, but to be honest, for the sake of an exam, whatever time you write on there is fine. So I've just written 8 o'clock, and because it's once only, I've crossed out all of the other times that you could possibly give it, and you write today's date, and that just starts that prescription. When it came to the furosemide, you wanted to prescribe him some IV furosemide. So that's the top one here. No, that's the bottom one, sorry. And it was BD. And the important thing is, say you actually gave someone like furosemide over 24 hours, you'd give it at like 8 in the morning, 8 in the evening. But there's a risk to giving it at 8 in the evening. Does anyone know what that is? Like what? I'm going to apologize for the noise outside. But what's the possible risk of giving someone a diuretic closer to nighttime? What does diuretics make you do? Basically, peeing at night. Exactly. Yeah. So nocturia isn't like, if it's secondary to the diuretics, you're not worried. But basically, if you if someone really needs to use the loo a lot at night, and they're slightly older, you're just making them even higher risk of falls. So don't do that. How do we know if the IV furosemide goes in the infusions bit at the back or the regular meds section? Okay, so in order to prescribe an infusion, you need to prescribe some form of fluid, and into that fluid, the drug has to be added. And we're not prescribing him any fluids at all. So if you want to just give something one-off IV or like an IV like medicine that just goes through his cannula, that can go in the regular sections or the once-only prescription. If you want them to infuse it with another bag of fluid, which we'll get to later, you do it in the infusion section. Does that make sense? He is catheterized, yeah. Okay, so then if we go on to the oral furosemide, the senior plan said hold it for 2 days whilst we're giving him IV therapy. So basically, same thing, you copy off the drug history, dose, oral route once daily, and then basically you're definitely holding it for 2 days. So cross out those 2 days worth of dates in the times bit. And it's not like it wouldn't be pass or fail, but you can always just in the IV bit, right, review in 2 days, consider stepping down to oral. You can just add it in 2 days. So this isn't a pass or fail thing, but basically if the reason why, even if you're holding, you always prescribe someone their entire drug history when they're admitted, is because it makes your life a whole lot easier when you get to doing their TTAs at the end. And not so much in this case, but if you take someone who takes an antihypertensive, and then for some reason that antihypertensive is stopped, if you know that that's on their drug history, if you know that that's held, when you get to starting them back up through their admission on that hypertensive again, you don't need to start at a lower dose. You know what used to work for them. So it's more just saves you time when you do ward rounds. And when you finally get to sending them home on the same medication they came in with. But yes, you could in theory add it in 2 days. Okay.
It's also worth pointing out it's good as like a trail of evidence. There's always a risk if you don't prescribe all of the regular meds on admission. Someone will be like, oh, maybe they just forgot to prescribe it and then they prescribe it later.
Yeah.
And I've seen this happen. We saw this lady I saw a lady come in with an overdose of gabapentin or something, and it wasn't put on her drug chart. Someone thought it had been missed out and then prescribed her gabapentin, even though she was being like treated for an overdose of it, because there wasn't like a breadcrumb trail. So like it is quite useful to just prescribe everything and make a clear remark that you've stopped it or held it for a reason.
Okay. So here's case 3, David Rose. He's a type 1 diabetic. He's generally been feeling unwell, come to A&E with worsening drowsiness.
Oh, 1 second. Sorry, there was just the question in the chat. I don't know whether we addressed it about whether you put something in the infusion section or the...
Oh, yeah, I did.
Yeah, so the easy answer is if you have access to a BNF, if it tells you it's an IV injection, then it's you just prescribe it in the regular bits. And if it's an infusion, you need to prescribe it as an infusion. That's basically the answer. So furosemide, you literally have pure furosemide and you stick it through their cannula.
Yeah.
There are exceptions to that rule. There are some drugs like calcium gluconate, which you give as like you need to prescribe as an infusion because it needs to be diluted in water. So basically, if you're unsure, you would check in the BNF to see whether it is an IV injection or it's an infusion. But they should tell you whether it's an injection or an infusion most of the time.
So now, before we continue the case, now might be a good time to tell you, you will always get the BNF in an OSCE station. And in my like mock OSCE, we were told this year, we were basically told if it's an electronic BNF, it's just the electronic one. If it's a paper BNF, they will open it up on the right page for you. So it is like a matter of just spamming the page to find the important bit of information. So it like you'll know whether it's an injection or an infusion, or you have the means to find it out.
Okay. Hopefully it will be the app, and in the app it literally is split into headings based on route of administration.
Okay, so going back to David, he is a diabetic, he's been feeling unwell, he's diagnosed with DKA, and you're given his ABG, you're given his drug history, and it says generally, please prescribe the appropriate therapy. So I'm going to give you 5 minutes again. This one is a little bit more thinking-y because I haven't given you a senior plan telling you do this, do this, do this. but think, what kind of things do you want to give to someone in DKA? You can use the BNF for this as well if you need to. I'll give you a bit more time. It's 36 now. Let's take it to 22. Give you 6 minutes to do this.
I think this is also a reasonable one that they could ask you to remember some doses off the top of your head. So this is one of the few things they could ask you to do without a BNF, technically. Or, well, the first bit of it anyway.
you've got 1 more minute left. If anybody wants to just let us know that they're done, we can start sooner. Also, if anyone wants more time, just let us know. This is the first time I've done this session, so I've got no idea how long you guys want to do it.
I think it's also worth pointing out that with this, if this was a station in your OSCE, there's only really 2 things they would ask you to prescribe, but we'll go over stuff in more detail past the first 2 things that you would immediately prescribe for completeness. But in an OSCE station, they would like limit you to just be like, do the acute prescriptions or something.
Okay, so I'm going to start. Okay.
Does anyone want to talk us through what they decided to do?
You don't have to share a screenshot or anything.
Yeah, you don't have to share a screenshot, just talk through, because I think it's quite useful, because this is what you'll be doing as an F1 in a few years. And this is a safe space. Anyone? If not, we'll go through it.
So I know you need to prescribe some 0.9% saline and also insulin. I didn't know exactly which area to put the insulin. I know the insulin dose is 0.1 units per kilogram per hour.
Yep.
Where
I think those are the 2 acute ones. I put the IV fluids in the infusions, and I did another one below the insulin. But I don't know if you can combine the 2, or what the like specifics are.
So you did them separately?
I did them separately under the infusions.
Yes, and that is exactly what you would do in real life as well.
I had a quick question. What was the systolic blood pressure? Because when I was looking in the BNF, it was talking about, it depends on the systolic blood pressure.
Oh, does it? Okay.
So,
maybe I was looking
which
in
bit of the BNF, sorry? God, sorry, I haven't read it.
I think it was more talking about if it was below 90, then you'd want to give, sort of.
Okay.
Yeah,
maybe I should specify. Okay, so he was hemodynamically stable. You didn't need to resuscitate him. Okay, fine. So in that part of the BNF, basically, so if he's hemodynamically unstable, you do like the whole A to E case number 1, the resuscitation fluids that we talked about. This one I should have specified he was fine. Okay, so let's go through it. DKA management, I've put the link up there, so when you get the slides, you can go over it if you want to. What are the sort of 3 key aspects of DKA management? Someone's already kind of said some of them. I feel like Patrick's already said it, so I'm just going to...
You want to give fluid and potassium.
Yeah, and insulin plus or minus the glucose. Yeah, okay, so let's do it one at a time. Start with the fluids. And monitoring. Always go back and monitor them regularly. So this is the bags that you'd give to replace their fluid deficit. So you'd start with a litre over 2 hours, another one over 2, 4, and 6. So on the drug chart, it manifests under the infusions bit. So it's just 0.9% sodium chloride, 1,000 mils. 1 litre is also fine if you put that there. Duration over 2 hours because it's the first bag. IV, no drug added to it. Sign for it. Cool. Okay. The next bit is the potassium replacement, and that's why I gave you the ABG. And his potassium was fine. You don't need to add it. You'd never, if you don't let me speak, you don't ever add the potassium in the first bag. That's right. But I've put it there just in case, so you guys know as an example of when you do add a drug into an infusion bag, this is what it looks like. So if you were going to, say, for example, in the second bag over 2 hours, add some potassium, that's what it would look like. And this is just a screenshot from the BMJ about when, like, what values are the cutoffs for when you add potassium and when you don't. Okay, so moving on to insulin. There's two aspects to the insulin that you need to prescribe for David here. One is his like fixed rate insulin. Let me just write it down. One is his fixed rate insulin, and someone said the rate, which was 0.1 units per kilo per hour. And the other is you have to continue his long-acting insulin. So if we start with continuing his long-acting one, oh, and glucose. The animations have just completely messed up. So this is when you get to, what's the cutoff for when you start prescribing glucose?
Is it 14?
Yeah, 14, exactly. So once their BMs drop below 14, you just add a bag of dextrose into the infusions bit. Again, it's not, the dextrose isn't infused into anything else, it's a fluid in itself. And you give it at 125 mils an hour, which works out to over 8 hours. Okay. The next one is his long-acting insulin. So his long-acting insulin is an injection. So it goes in his regular prescription. And with insulin, you always write insulin glargine or the actual name of the insulin in the BNF. Don't write the brand name. And the dose is in units, it's IV or subcut. So for this case, it's subcut. I would be shocked if they expected you to write like pump insulin, but just I wouldn't worry about pump insulin basically. And it's the same as a usual regular prescription. So you write down the time you want it, cross out all the other times, write the start date. And in the additional information, you want to write that if they're on insulin, you want them to check their BMs regularly, so the nurses know to keep a blood glucose chart. Okay, so the fixed rate insulin is where it starts to get a bit complex. So if you had gone to the BNF, this is what you would have found. It would have said start an IV infusion of soluble insulin mixed with some sodium chloride at a concentration of 1 unit per mil and infuse it at a fixed rate. Okay, so David's weight was 58 kilos. So if we wanted to give him 1 unit per kilogram per hour, that's 5.8 units. Is that bit still clear, right? Yes, I'm going to go with that. So his duration can actually be a rate. So you just write 5.8 units per hour. If you typed it to the BNF after you read this, soluble insulin, the way they would have told you is it comes in a preparation of 50 mils, or it comes in a preparation and you always mix it for 50 mils of sodium chloride. For those of you, and I know some of you have volunteered, you could have also guessed this, because if you think about the syringe that goes into an infusion, think about what you guys used to see on ITU, they were always 50 mil syringes. So it's always prepared up to 50 mils. So basically you want 50 mils of your sodium chloride fluid, and into that you want to add 50 units because the concentration has to be 1 unit per mil, and you want to infuse that at 5.8 units per hour because that's how much he weighs. Is this clear?
That's clear. Yeah, I've just got a quick question.
Yeah.
I noticed when I was on the wards, the drug charts that I was looking in had like a separate section for insulin.
Yeah, it will vary so much, but this is almost like, this is definitely the only drug chart you will get in the exam. So if we are doing it for fourth year, I would just learn it for the exam, how to prescribe it on the Good Hospital drug chart. If you're doing it for F1, we can debate whether it's worth it because it might just be online as well. So
yeah, also so the insulin charts so are often used for sliding scale insulin, which is not something you'll be expected to prescribe. So that's for generally inpatient diabetics. They all generally get put on like a sliding scale insulin regimen, and that is a separate chart. But you will not be expected to know anything about that for exams.
Something that I
with
could.
the insulin,
Yeah,
is it
sorry. Go for it.
always going to be 50 units and 50 mils?
Yeah.
Is it ever going to be more?
Not that I could find on the BNF, no.
Okay, sure.
And
No, it's always that.
to be honest, like I've never seen one physically bigger than 50 mils either, so very unlikely. Maddie says
in terms of if this was a station, we'll talk about what is a likely station after we've gone through it. We'll tell you which bits are likely to come up in like one cohesive station. We'll get to it.
The other thing that I haven't added to this because just space, but have a go at doing it yourself, is prescribing the mealtime short-acting insulin and then holding it until he has his DKA treatment. If the infusion is repeated, how do you indicate that? You physically re-prescribe it. That's the only way. Because they have to sign for it every time they do it. So it would just be underneath. Don't ever do like the whole, as in I've seen it done, but for an exam, don't ever do the whole like 2 lines, which means same as the thing above it. How do you show you're holding the bolus regimen? So let me just check what I wrote for what his bolus regimen actually was. Too far. Okay, so he's on Humalog 4 to 8 units before meal times. Okay, so what you do is you go to your regular prescriptions and you would write whatever the BNF says for short-acting insulin. I think it's like Actorapid, and then you can always in brackets write Humalog. You'd write 4 to 8 units. You can put a range in the dose, and then in the additional information, you can do like adjust units based on meal content and size, etc., or oral intake. You'd write the route as subcut, sign for it, and then the frequency you'd put TDS because he probably has 3 meals a day, and you'd put the meal times as the time on the chart, and then you would basically write today's date on the chart, and then you would cross out for the meal times under today's date because he's definitely not going to be eating today or coming off, like he's definitely not coming off DKA treatment today. So you just cross off those small boxes under today, and then every time you review it, you'd cross off for whichever date it is. Does that make sense?
I think it's worth pointing out that it's very unlikely that they'll ask you to ever prescribe an insulin regimen. It's quite complex, and a lot of it is patient dependent, and it's one of those diseases where the patient is very much the expert on their condition. So like I wouldn't worry too much about like prescribing insulin regimens. Just remember to keep the long-acting insulin. That's like a big learning point.
I'll show you another way to hold something a little later in the next case, or later in David's life. But yeah, come ask me again at the end if you're not sure. Okay, so David is recovering well from DKA on Creek ward. If no one still doesn't understand the reference of these names, please go on Netflix and watch something. Okay, so during the ward round, he complains that he had some dysuria, foul-smelling urine, nocturia leading up to coming in, and you decide to start him on some antibiotics. Please prescribe the most suitable antibiotic for him, given the most likely diagnosis.
Quickly, before you start the time for that, to go back to Maddie's questions, if this was in an OSCE, they would ask you to prescribe the immediate management of DKA, which would have been prescribe the Actrapid 0.1 units per kilo per hour and the first bag of fluids. That would be your brief. They would tell you exactly what you needed to do, so you wouldn't really need to do anything else.
So yeah, you can use the BNF for this. This should be relatively straightforward. So I'm only going to give you 2 minutes for it. And also because we're kind of running out of time. Sorry.
You can skip the patient identifiers for this one.
Yeah.
Sorry, I just saw Jordan's question about if an infusion is repeated, how do you indicate that? You can't repeat infusions, you have to prescribe them new every time. It's annoying, but life.
Okay, you've got 1 more minute. Okay, so does anyone want to tell me what the most likely diagnosis is here?
Is it a UTI?
Yeah, he's got a UTI. If I was to tell you he had, if on the presentation he was also really hypotensive, he had really high fever as well, what would be the other big diagnosis that you want to consider?
Pyelonephritis.
Exactly, yeah, urosepsis. Okay, so he had a UTI, and what were the 2 drugs that you found on the BNF, or maybe just knew off the top of your head, that you could give him for a UTI? Trimethoprim or nitrofurantoin. Yep. And sadly, we have to learn how to spell all of these antibiotics. Okay, so if you'd gone on the BNF, it would have said for men, you could have given nitrofurantoin or trimethoprim first line. Can you give these if someone is penicillin allergic? The answer is yes, because I've obviously shown you the prescriptions. But yes, you can. The only non-obvious one that you have to look out for is tazocin, because tazocin is actually like piperacillin and tazobactam. So you can't, the name doesn't tell you that it's got penicillin in it. But nitrofurantoin and trimethoprim are both safe. So depending on whichever one you went for, you could have given, you could have written this prescription. And what's important is, do you see here there's squiggly line where I've crossed out the times that you don't want to give it, and then I've kind of gone into the times in the last column. That basically means that date you have to end it on. So after 7 days, you should stop it. They won't, on the column for the 8th day, you can't prescribe it. And that's how you can put a set time definition on these charts, because it doesn't say how long for, but you don't, the full course is only 7 days. And with the trimethoprim, with the nitrofurantoin, sorry, I can't read, you have to make sure you give either a modified release or a normal standard release one, and get the correct dose for each of those, basically. So that's just a thing that the BNF doesn't quite tell you as clearly. Any questions about that before we move on? Can we not prescribe for catheter-associated UTI? David was not catheterized. The guy with the heart failure was. How do we know if it's modified release or immediate release? Okay, so this is something that I found really hard. I used to get to the page in the BNF where it was nitrofurantoin or trimethoprim or normal release or modified release, and I'd be like, which one do I choose? To be honest, they're both right. It doesn't matter as long as you get the correct dose written down. So it doesn't matter actually which antibiotic you picked or which preparation you picked, as long as it's the correct dose and the correct frequency. Because there will be scope. So in my 5th year mock OSCE, the prescribing station had scope for loads of different ones based on which one you picked. So there'll be leeway. Okay, so final part of David's admission. He's coping well on day 2 on his antibiotics, his DKA is resolving, and his bloods show the following. And the question is, what is the single best description for the blood test abnormality that you can see? We can't really do a poll, so I'm going to give you 30 seconds to think about it. Everyone write down a letter, a number.
Yeah, sorry, I didn't have time to set up the Menti.
It's okay. Okay, anyone want to volunteer an answer? Please. Even if it's wrong, it's okay. Okay, well, I'm going to show you. So the answer is 4. He's got a stage 1 AKI secondary to dehydration. So let's talk through this. What ways do you know that you can evaluate an AKI? What are like markers in the blood that you can use? Sorry, it's a really awful worded question. What I'm trying to get to is basically you can tell, yeah, yeah, so you can grade the AKI by stages based on the creatinine rise. So he's got a creatinine rise, which is 1.5 to like 2 times the normal. And that's what makes it stage 1. And you can sort of work out the source based on the urea to creatinine ratio. And I have a really good way for explaining it, which I've put in the bottom of the slides. But we can do a whole other session on AKI if you want, just put it in the feedback form. But basically, your urea to creatinine ratio hints at what the cause could be. So he's not got pre-renal AKI, secondary to dehydration, because his urea to creatinine ratio is like 38 to 1. He hasn't got a renal one secondary to trimethoprim, because yes, his urea to creatinine ratio is right, but if you looked in the BNF and also generally, trimethoprim doesn't cause renal damage. It's not post-renal, and we know it's not pyelonephritis because I didn't give you any indications into the question that he was like, you know, back pain, spiking temperatures, and I told you he had a UTI. And it's not really progression of CKD because his renal function was fine when he was admitted. So you knew he had DKA, you knew that caused profound dehydration, and you could be sure that he fulfilled the criteria for stage 1 AKI. So this is stage 1 AKI secondary to dehydration. Okay, so the next question is, he has an AKI, and these are his regular medication. What are you going, or this is not his regular medication. This is me getting him confused with the heart failure person. But new person, new case, they have an AKI. These are their regular medications. What do you want to stop? Oh no, David does take ramipril and tristatin. He does, excuse me, sorry, I'm going mad. What do you want to stop? Take away his ramipril. Yeah, perfect. Okay, so I want you guys to really quickly, copy out his ramipril prescription and then cross out how you would stop it. We are also almost at the end, so sorry for running over, but we're almost done. Okay, does anyone want to tell me how they've crossed it out? Describe what your piece of paper looks like right now.
Massive squiggle through everything.
Okay, good. So there's 2 ways you could have done it. You could have put a massive cross or squiggle through everything, or you could have, so this is what I was saying to Jordan, where you can cross it out day by day. You could have crossed out just sort of the time that you definitely know he won't be having it. So for an AKI, you could maybe say 2 days. And in the comments, you could write, hold until this date, review and consider recommencing. Regardless of what you do, always write down that you've done it and why you've done it. So I haven't really, but if you crossed out the whole box, next to it in the margin, you can always write stopped, your signature, the date, and maybe just like AKI in brackets. And it just keeps that flow of documentation going. So everyone knows why something's happened. Yes, granted, half the time you can't read why, but whole different issue. Okay.
I have a bonus question. Just put Preena on the spot a little.
No.
As in, you don't need to answer it, but can anyone spot an error on Preena's prescription of Ramipril? This is a learning point, which is why I didn't correct it when I saw it in the slides. And I've done the PSA recently, so this is why I can see stuff like this.
This is why I put a disclaimer in the first slide. I haven't done
Ramipril, not Ramipril.
Yes, there is a spelling mistake.
Sorry.
There is one other thing. Does anyone know what one of the big side effects of ACE inhibitors is? What are some side effects of ACE inhibitors?
Dry cough.
Dry cough, yeah. That's not the one that's the issue here, but yeah, that is one of them. Any other ones?
Angioedema or something.
Angioedema, also not the issue here, but yes, good. What happens to the blood pressure? Hyperkalemia is an important side effect, but also is unfortunately not the relevant one here. This is a good learning point. So ACE inhibitors and ARBs are both associated with postural hypotension. So you should prescribe them in the evening to reduce the risk of falls in patients, especially in elderly patients. So if you prescribe ACE inhibitors and ARBs in the evening, yes, they cause some diuresis, but it's better than causing the postural hypotension. Okay. Sorry, that was just, okay. It's a good learning point there.
So this is the last slide, and it's just a summary for, could you write that once nightly? Yeah, of course you can, yeah. Okay, so drugs that you would hold during an AKI. NSAIDs, does anyone know which NSAID you can continue safely during an AKI? What do you give for after someone's had an MI or a stroke? Aspirin, yeah, exactly. You can continue aspirin, even though it is technically an NSAID, but you can continue it during an AKI. ACE inhibitors and ARBs, do you know why you stop it during an AKI? What part of the nephron do they act on? I have to make sure I get this right. Okay, so they, not quite. So basically they act on the artery. Yeah, so they act on the artery, and in an AKI, you don't want to constrict the blood flow even more. So if you give an ACE inhibitor and it causes the arterial to constrict, it reduces the blood flow and makes the AKI worse. So don't give it. Does anyone know why you don't give metformin in an AKI? Or what's the consequence you're trying to avoid? Build up of metformin not renally cleared. Yes, yeah, exactly. You're trying to avoid acidosis. Yeah, it can lead to a metabolic acidosis through a mechanism I don't know off the top of my head. Lithium and digoxin. So lithium and aminoglycosides, Anush can talk about this a bit better than I can, clinically are like a case by case. Oh, they've got an AKI, but they kind of really need this medication, risk benefit. For an SBA is the answer that you choose to stop. In real life, it's a bit more case based. Is that right?
Yeah, we'll talk about it in a minute. I'm just going to press feedback in case any of you need to go off and have dinner.
Yeah.
But like,
That's the
yeah,
last
so like the kind of challenge with aminoglycosides especially is you might have seen a lot of patients on gentamicin for treatment of infections, and then the gentamicin causes an AKI. In situations like that, you can't really stop the gent because, like, obviously treating like endocarditis or bacteremia is more important than the AKI. But like, so you'd probably consider like renal dosing it, so you'll adjust it for their EGFR. It's a similar thing potentially for lithium because patients usually take lithium for things like bipolar disorder, and it's quite dangerous to stop it just acutely because they can become manic. So there's always like a risk-benefit analysis. But yeah, in exams, these are the things you want to stop. And yeah, as Preena said, continue the aspirin. Like, absolutely continue the aspirin. Do ACEs, ARBs affect both efferent and
No, it's
afferent?
just the afferent. Yeah, so ACEs and ARBs affect the afferent, and then NSAIDs affect the efferent. And basically, they just constrict or dilate in order to reduce the blood flow in the glomerulus. That's how I remember it.
I think you mean the other way around, Preena.
Yeah, sorry.
Yeah.
Read about that.
So ACEs and ARBs is the efferent, and NSAIDs is the afferent.
That is what I said.
Is that what you said? Oh my god,
Yeah.
now I'm losing my mind. Sorry.
Also, just on the note of renal dosing, you'll notice that in some of these questions, I gave you the renal function and it was completely fine. But if they've given you specific, if they've not written like FBC, NAD, they've actually written out the renal function for you, double check that it's not abnormal and that you don't need to adjust the dose. Again, like in their past medical history, double check they don't have CKD.
They won't ask you to prescribe for renal dosing, but they will expect you to stop drugs with regard to AKI.
Yeah.
Because no one truly understands renal dosing except for renal doctors. And occasionally renal F1s.